to start is a very important part of intersex trans and gender diversity, as went through the trans and gender diverse. Now, to talk about intersex, Morgan Carpenter. Morgan is a social and economic policy researcher who works for an IT company. Morgan came permanently to Australia on a 457 visa in 2005 and is now a citizen. Also the president of organisation Intersex International Australia since 1st of September, if I may, following from the great work of Gina Wilson, who has just been amazing. Morgan will keep up the announcement. And previously the Secretary has been directly involved in actions around the anti-discrimination legislation which Jazz mentioned, and also gender recognition and health guidelines, and very importantly the Senate inquiry on involuntary or coerced sterilisation, which affects many people experiencing intersex. So please welcome to the microphone and replica, Morgan Carpenter.
Hi, it's good to be here. I'd like to acknowledge the Wadawurrung people as the custodians of the land on which we gather, and their elders past and present, and Indigenous people today. So what I'm going to do is introduce Intersex for people that haven't heard much about it. You've heard Bonnie talk this morning. You may have heard Tony speak as well, and it's actually amazing to have so many intersex people here visible. This is actually quite exceptional. Yay! It happens occasionally in Sydney and Melbourne, but we're not even in Melbourne. I'm going to focus on health issues, and some of this will be confronting. It'll be information dense. I'm happy to give references to anything that I'm going to talk about this morning, and if you want to talk to me later about this, that's all good. I'm approachable and happy to talk about this stuff, so please, don't see me as like the bad cop telling you the confronting stuff. What I'm going to do is give you more clarity about our issues and awareness of current actions that we're working on, some of which are LGBTI actions or even intersex and trans actions, some of which we're working on by ourselves. OAI Australia is a volunteer-run community organisation, as is AIS Support Group. There are no funded intersex organisations in Australia. So, intersex is a term that relates to biological traits or variations that lie between male and female. Intersex is always congenital, and it can originate from genetic, chromosomal, or hormonal variations. It's an umbrella term for a huge range of diagnoses. And many are testable via amniocentesis, ultrasound, or chorionic case. Many intersex variations are precisely defined, others are not so precise. Olaf Hirt in Lübeck in Germany said at a symposium this year that there are over 40 different entities, most of which are genetic. And an exact diagnosis is missing in 10 to 80% of cases. Now, just even that extraordinary range just shows you that there's so much that isn't yet understood about intersex. If we include chromosomal variations as well as other diagnoses, more physically apparent diagnoses from birth, then possibly around 1 to 2% of the population might be intersex. The numbers are very sketchy. You can look at some work by M. Fausto Sterling or Blacklist and others in the Australian Journal of Human Biology in 2000. But numbers are somewhat speculative. And when testing is possible via amniocentesis or chorionic villus, what that results in is terminations of intersex fetuses. So for some variations, like 47XXY, there are studies that show 88% of fetuses diagnosed with 47 MSXY are terminated. Although organised intersex people in Australia use the word intersex ourselves, the term is contested. In the view of OII, intersex is the most widely known term, simple, and the least stigmatising term available. But we are regarded by medicine as having a disorder of sex development, or DSD, which affects our genitals, gonads, or chromosomes. Some overseas intersex organisations refer to differences of sex development, but neither of the two intersex organisations here use that terminology. Effectively, what the medicalisation means is that intersex is seen as an impairment. And if we look at the World Health Organization, it defines a disability or disabilities as an umbrella term covering impairments, activity limitations, and participation restrictions. An impairment is a problem in body function or structure, and disability is not just a health problem, it is a complex phenomenon reflecting the interaction between features of a person's body and the features of a society in which he or she lives. Overcoming the difficulties faced by people with disabilities requires interventions to remove environmental and social barriers. So, those definitions apply to intersex because of the way that we're medicalised. And we're medicalised, stigmatised, and suffer discrimination due to our characteristics, our sex characteristics, which affect perceptions of our realness as men or women. Intersex is not about sexual orientation. We have as diverse a range of sexual orientations as non-intersex people. Intersex is not about gender identity. We have as diverse a range of gender identities as non-intersex people. And you can see that. Bonnie was up on stage earlier, I'm here now, Tony is speaking later. There's a diverse range of different ways in which we see ourselves, but we share characteristics in common that are fundamentally about the way that our bodies have been treated. Katrina Karkazis, in her book Fixing Sex, 2008, said, gender atypical genitals and bodies create anxiety about the borders of properly gendered subjects and a desire to reaffirm those borders. In a culture that requires clear gender division and a true sex, gender atypical bodies threaten an entire system of laws, rights, responsibilities, and privileges built upon notions of discrete and binary gender. So, intersex people have non-heteronormative bodies. Our bodies do not meet societal expectations. Cultural, familial, and medical attitudes govern to which sex we are assigned, and surgical and other medical interventions are made to ensure that we conform to those norms. They erase intersex differences. We are sometimes part of the LGBTI movement because of a homophobic response to our bodies. We're defined by what is done to us, those of that class. These are different issues to those facing trans people, who are assigned on the basis of no atypical physical sex characteristics. And if we look at OII Australia, every individual intersex member of OII Australia has experienced some form of non-consensual or coercive medical intervention, including pressure to conform to gender norms and to be a real man or real woman, involuntary sterilisation and clitorectomy, that's clitoris removal or reduction, as an infant, child or adolescent, medical and familial pressure to take hormone treatment, medical and familial pressure to undertake genital normalisation surgery, surgical interventions that go outside the terms of consent, including surgery that was normalising without consent, disclosure of non-relevant medical data to third parties, and being paraded in front of medical students. It's important to recognise that parents often don't get good information. They still don't get enough information. They don't get enough to make truly informed consent. And they often do the best job they can in the context of little and skewed data. It's also important to say, some doctors are good. Bonnie mentioned her GP. My GP is the best ally I've ever had in some ways, and has been on an amazing journey with me through diagnosis and treatment, some of which has been very difficult to handle. The origins of medical treatment protocols lie with a now discredited theory by Dr. John Money, who you might have heard of. He developed a theory on the social construction of gender, which was expressed or articulated in some ways in the David Reamer case of a boy raised as a girl after a botched circumcision. He claimed the experiment was successful, when it actually wasn't. So he created this, he helped to create a situation where genital surgeries for psychosocial reasons became the norm. A normal appearance is deemed justifiable, deemed desirable to enable adjustment to society. That continues today, even though Money was working in the 50s. A foundational 2006 consensus statement on intersex disorders and their management was agreed by a group of clinicians that coined the term DSD, and it defined psychosocial rationales for surgery on infants and children as minimizing family concern and distress, and mitigating the risks of stigmatization and gender identity confusion. That's the basis for a 2013 Victorian Health Department decision-making framework on the treatment of intersex infants and children, which this year explicitly cites cultural, social, and other psychosocial rationales for surgery. And here's just two of the bullet points on what constitutes psychosocial rationales. Risk of social or cultural disadvantage to the child. For example, reduced opportunities for marriage or intimate relationships, or reduced opportunity for meaningful employment and capacity to earn an income. Risk of social isolation, restrictions or difficulties, for example, caused by embarrassment or social stigma associated with having genitalia that does not match the gender in which the person lives. So, with respect, these social risks might equally apply to women who have not undergone female genital mutilation in societies where that is the norm. Marriageability, social and cultural disadvantage, and social stigma. But these are the guidelines that are in place today in this state. And Victoria is the only state in Australia to have a published policy on what happens to intersex infants, children, and adolescents. It's a framework document. It's not even compulsory or obligatory. We have some anecdotal evidence for what happens in New South Wales and elsewhere, but we don't actually know what happens elsewhere in Australia. We know that 10 to 15 cosmetic surgeries on infants take place each year at the Royal Children's Hospital in Melbourne, but we don't have data from anywhere else. So, clitorectomies, clitoral recession, and other genital surgeries are carried out now, today, this year, without patient consent, because patients can't consent. There is deemed to be an acceptable expectation that the children involved will grow up to be a specific gender. For example, often these surgeries take place on infants with 46XX CAH, congenital adrenal hyperplasia. XX means that they have chromosomes typically associated with being female. And we know that 8.5% of people with 46XX CAH will go on to change assignment in later life. Surgery is not just on infants. Many young people with complete AIS have been sterilised. Bonnie gave an example. And many young people with other intersex variations are still being sterilised in their childhoods or adolescence, without firm data on risks. Some Australian reports quote highly generalised upper bound rates of 30%, even 50% in terms of risk of cancer from gonads. In a couple of rather more narrowly defined studies, looking at specific intersex variations like complete AIS, the risks quoted are like 0.8 to 2%. We know that the lifetime risk of breast cancer in women is about 12.2%, but we don't routinely remove women's breasts on the basis of that cancer risk. There are some concerns about how easy it is to monitor internal gonads, and times are changing, as Bonnie mentioned. We've been told that RCH hasn't routinely removed gonads in people with complete AIS in the last 10 years, but we have no firm data from anywhere else. Actually, that even isn't firm, that's anecdotal. At OII, we believe that there's been an overuse of sterilisation as a means of imposing a gender identity on a child, which affects the quality of data we have on the cancer risks going forward. When gonads are removed, you can't monitor them, you can't actually work out what the real cancer risk is. And that's part of the reason why the quality of data on these issues is so poor. So, looking in more details from the justifications, I've told you about psychosocial rationales, but in terms of what physicians, clinicians are saying about surgeries, there is currently in progress a Federal Senate Community Affairs References Committee conducting an inquiry into the involuntary or coerced sterilisation of people with disabilities, including intersex people. And there are two key clinician submissions. Both of them have a Victorian flavour. One is by the DSD team at the Royal Children's Hospital, and the other is by the Australasian Paediatric Endocrine Group, or APEG, and two of the four authors are based here in Victoria. And a few quotes from those submissions. RCH say, "We acknowledge that outcomes related to current approaches remain to be established." APEG say, "There is limited evidence reporting long-term outcomes of early surgical management for reasons of appearance. The few outcome studies reported have conflicting results of good and poor outcomes, cosmetic, sexual or psychological, with particular concern regarding sexual function and sensation." So, for surgeries that are regarded as being cosmetic, there's a particular concern amongst clinicians about sexual function and sensation. There is also a lack of data, long-term follow-up, and long-term support. APEG say, "Current international guidelines recommend long-term follow-up of children with DSD who have early surgery. This does not occur in Australia, as there is no coordinated registry regarding the management and outcomes for people with DSD." They also say, "A major concern in medical management, both in Australasia and internationally, is with deficient psychosocial support, particularly as a young person with DSD becomes older." RCH say, "Follow-up studies to assess the impact of our current approaches on outcomes in various subgroups of DSDs are required." APEG say, "Improvements in care for individuals with DSD will not occur without improvements in clinical service provision and research and funding. APEC say, we are in the process of performing a study of the recommendations on surgical timing across the clinicians in our organisation, because they don't have any data. Sterilizations, clitorectomies, other genital surgeries, and other sexually normalizing surgeries have lifelong health impacts. Sterilization turns us into lifelong patients, even if it's the only intervention carried out. We need HRT, estrogen, and oral testosterone for the rest of our lives, with consequential and not fully understood risks. The impacts of surgery can be seen in a high prevalence of lack of sensation, repeat surgeries, infertility, scarring, painful intercourse, depression, and trauma. And as a rule, research on intersex people is conducted by non-intersex pediatric clinicians based on small samples and case studies of people who have been treated by the institution conducting the study. That means there is sample bias and selection bias. And there are only 1 or 2 pilot studies that look long-term across multiple institutions, and there is little research on adults. And by adults I mean young adults as well as other adults, older adults. Jared Conway of University College Hospitals in the UK commented on this year in a study presented at a symposium in Glasgow, and focusing on women in particular at risk of cancer, or possibly at risk of cancer. He had this to say: care of adults with DSD poses many challenges, not least because most information in the field is based entirely on pediatric experience. There is little guidance for making an accurate diagnosis in adults. Furthermore, the group of women, often over that age of 25, for whom paediatric care might not have been transparent in terms of accurate diagnostic information, may have a legacy of psychological issues that hinder engagement with medical services. In the surgical field, adults with DSD have to cope with variable outcomes from genital surgery that require ongoing care. Medical aspects of an adult DSD service include optimization and an individual approach to sex steroid replacement, as well as long-term health surveillance such as monitoring bone density and cardiovascular risk. In a world where individuals attending an adult DSD service are often highly informed experts in the field, the role of medical care is often to guide on safety aspects and accept that the evidence base from which conventional practice has developed is questionable. I mentioned that there are a couple of pilot studies that look longitudinally at multiple institutions and people who have not been studied, not been treated by the institution conducting the study. Of those pilot studies, Schutzman and others in 2007 found prevalence rates of self-harming behaviour and suicidal tendencies of the intersex cohort were comparable to traumatized women with a history of sexual abuse. And a 2005 study of adults who've been treated as patients at the RCH in Melbourne, treated according to their own protocols in their own hospital, found the intersex cohort were similarly as distressed as a comparison group of chronic somatically ill persons. And somatically ill means bodily ill. So, accessing adequate healthcare can be an issue for us as adults, and adults are subject to the same pressures to conform to societal and medical expectations as infants and children. In my own case, I was diagnosed very late, in my 30s. I wasn't diagnosed late because the issues were not evident. I was diagnosed late because it was at that particular time when I was dependent on my partner for an income, because I was unemployed and a student for a period. I pretty much take testosterone to become a real man. A year after diagnosis, I had the first of 4 surgeries that took place within 4 months. And those surgeries involved sterilisation and other treatments. And the outcome of one of those surgeries was non-consensual. What can happen to you as an adult, even when you believe that you are in control of a situation or a process. I was not in full control of that process. And I was not in control of that process, both in terms of the family environment that I was in or medically. The kinds of issues that our members have had at OII include failure to treat adequately an issue because only issues relating to our legal gender were explored. We've had Medicare cover declined for treatment that was thought of as being inappropriate for someone of our legal gender. We have situations where treatments as adults that are deemed to be aligned with legal sex generally proceed without counselling or support, even though those treatments are as life-changing as treatments that are thought of as being cross-sex treatments. And even where counselling is given, the assumptions about what is appropriate can be inappropriate. And OII member Michael Noble says, around the age of 23, an endocrinologist discovered that my body had never produced enough testosterone for me to undergo a full puberty. He therefore suggested I commence testosterone therapy. Initially I resisted the pressures placed on me to commence therapy, yet eventually I crumbled under the constant onslaught of threats and horror stories of what my future would be like if I didn't undergo therapy, which doctors claimed would turn me into a real man. It was insinuated, even blatantly stated on occasions, that my life would be worthless, that I would be a freak, that I would never achieve my potential, and that I would never have any self-esteem. Apparently the self-esteem I already had was invalid as it existed outside of the predefined paradigm of being a real man. So eventually I began testosterone therapy, and Michael found it a horrifying experience. Testosterone therapy generated profound and traumatic changes. I lost contact with who I was, and thus my sense of self. I lost contact with my heart. Worst of all, the therapy turned me into somebody I was not. So, treatments that are not aligned with legal sex result in diagnosis as disordered or dysphoric, which people here might be more familiar with. And the diagnosis is based on the assumption that one set of gender-affirming treatments is necessarily more valid or appropriate than another. It obviously affects intersex people who have had one assignment of sex surgically reinforced and who later change that. And the numbers of those intersex people vary from 8.5 to over 60%, depending on their diagnosis. But it also affects intersex people who are comfortable with their assignment. For example, a person with complete AIS who has XY sex chromosomes has internal testes. Yet their bodies develop partially or mostly along female lines because of the different way their body responds to androgens. If their testes are remained, women with complete AIS can avoid any requirement for HRT, but will go through a natural female puberty, developing predominantly female sex characteristics. But when they're sterilised, women with AIS are not offered a nature-identical replacement for the hormone that their bodies naturally produced. Because they're women, they're offered estrogen, which is the hormone produced by ovaries. Women with AIS who wish to replace the hormone they used to produce with an identical hormone may be considered to have a gender identity issue. Currently, a German study is making a formal evaluation of testosterone for women with complete IS. So that is currently being documented in Germany to make it hopefully become more widely available or acceptable at some point in the clinical setting. Now, I could talk about how things begin very early in terms of prenatal diagnosis and the impact of prenatal diagnosis on terminations and in terms of prenatal treatments, for example, for CAH. There's a whole body of research in that area, dating, for example, from 1991 with a doctor called Heimer Meyer-Balberg, who published a paper called Will Prenatal Hormone Treatment Prevent Homosexuality? That by 1999 became what causes low rates of childbearing in CAH. Because women with CAH have low levels in getting married and performing traditional childcare housewife role. I'm going to leave that because of time. I'm going to move on. To recap, the Australasian Paediatric Endocrine Group deems surgery is necessary for psychosocial reasons, such as to allow the child to develop without the psychosocial stigma or distress, which is associated with having genitalia incongruous with the sex of rearing. This year, the UN Special Rapporteur on Torture talked about infant surgeries on intersex infants and also reparative surgeries on trans intersex people. On intersex, the Special Rapporteur said, children who are born with atypical sex characteristics are often subject to irreversible sex assignment, involuntary sterilization, involuntary genital normalizing surgery, performed without their informed consent or that of their parents in an attempt to fix their sex, leaving them with permanent, irreversible infertility and causing severe mental suffering. And he described those treatments as a form of torture. In June, the Council of the European Union mentioned the same issue. On Monday last week, 1st of October, the Council of Europe, a different institution with 47 member countries, including Turkey, Russia, agreed a resolution to protect children's right to physical integrity, saying the Parliamentary Assembly is particularly worried about a category of violation of the physical integrity of children, which supporters of the procedures tend to present as beneficial to the children themselves, despite clear evidence to the contrary. And on intersex, they say they want member states to undertake further research to increase knowledge about the specific situation of intersex people, ensure that no one is subjected to unnecessary medical or surgical treatment that is cosmetic rather than vital for health during infancy or childhood, guarantee bodily integrity, autonomy and self-determination to persons concerned, and provide families with intersex children with adequate counselling and support. Now that's kind of somewhat different, the situation in Victoria. There are doctors who are speaking out against these treatments. It's not just community representatives that are doing this, or parliamentarians even. But clinicians are currently still few and far between. And a guy called Mika Venhola is one of the most senior so far. He's a paediatric surgeon in Finland, who's deputy chief of the University Hospital Paediatric Department. And he says the treatment paradigm of intersex conditions is debatable, and clinicians are in confusion as to the best management of intersex. He also says evidence of proper treatment is lacking. Intersex is an ethical problem as full disclosure, informed consent and children's rights are not unquestionably respected. Why operate on the children's body if the problem is in the minds of the adults? Switzerland has a state-of-the-art. The Swiss National Advisory Commission on Biomedical Ethics apologised last year for past treatment. And they say that all non-trivial sex assignment treatment decisions, which have irreversible consequences but can be deferred, should be. So there is here currently a Senate inquiry on involuntary or coerced sterilisation, and it's worth looking at the submissions to that inquiry, and you can see the full range of submissions from both clinicians, community organisations, including OII and the AAS support group. I just want to very quickly summarise and say, what do we want? We experience homophobia differently, not because of our identities, but because of our bodies. Mental health issues we face arise from issues around abuse, trauma, deficient psychosocial support. Physical issues include lack of sensation, sexual function, fertility, the effects of sterilisation. And like trans people, we want to live in a society where we're not obliged to conform to sex and gender norms, where our biological distinctiveness is not treated as shameful or a behaviour, and we're protected and not othered as a class.